I'm very excited today to introduce our panel on marijuana for PTSD. We have Felipe Lucas, Suzanne Sicily, and Zach Walsh. Zach Walsh, PhD, is a clinical psychologist and associate professor of psychology at the University of British Columbia and is the lead investigator for several ongoing studies of the therapeutic use of cannabis, including a clinical trial of cannabis for PTSD. Dr. Suzanne Sicily, MD, is an institute member of the American Telemedicine Association and serves on the ATA's Legislative and Policy Committee. Sue also serves as a clinical faculty at St. Joseph's Hospital and Medical Center at the Mercy Care Adult Medicine Clinic for patients. And Felipe Lucas, MA, is Vice President, Patient Research and Access at Tilray, a federally authorized medical cannabis production, research, and distribution company, a research fellow with the Center for Addictions Research of British Columbia. Please welcome our panel today.
Thank you so much. It's a real pleasure to be here with you today. I want to thank the 20 of you or so who didn't overindulge last night so you can make the first panel. I want to thank the other 20 of you who indulged too late to go to bed, so you're here with us today as well. I'm not here to judge. I'm going to start out today with a really brief overview of the federal medical cannabis program in Canada, just to give you some background. I'm going to talk a little bit about the biochemical reasons why cannabis might be useful in the treatment of PTSD. I'll go over some novel data on substitution effect and then show you guys a short film on a patient using cannabis for PTSD before turning it over to Dr. Walsh, who's going to talk about the PTSD clinical trial that we're working on together between Tilray and UBC. So Canada was one of the first nations anywhere in the world to have a medical cannabis program, but it didn't come about because any of the major parties in Canada decided to do anything compassionate for critically and chronically ill Canadians. It really came about, like all medical cannabis programs, because patients demanded legal, safe access to medical cannabis. And there were two patients in particular, a gentleman named Terry Parker with MS, a gentleman named Jim Wakeford with HIV/AIDS, who the people who were providing them cannabis kept getting arrested for trying to make this available to them. And they made their way all the way up to the Supreme Court of Canada, where it was established that Canadians had a legal, constitutionally protected right to access medical cannabis in Canada. And in fact, our entire Controlled Drugs and Substances Act is dependent constitutionally on there being access for patients. So it's not something one party can reverse or another. It's a constitutional guarantee in Canada. So in response to this court decision, Health Canada in 2000 established the Medical Marijuana Access Regulations, or MMAR. It was a really challenging program. You can imagine when you're pulling a government into a program unwillingly, they come in kicking and screaming. It was buried in Health Canada for a long time. And in the first 10 years of the program, it was actually sued over 300 times. It was found unconstitutional over 10 times. In other words, it was acting illegally in terms of not providing safe access for patients who needed medical cannabis. And in fact, by the end of the first 10 years, Oregon had more medical cannabis patients signed up in its state program than the Health Canada program in Canada, despite Canada having 10 times the population. So a few years ago, Health Canada decided to change its approach, and it licensed large-scale licensed producers to make cannabis available to patients. Before that, we had a single company legally allowed to produce a single strain for patients in Canada. And despite the fact that strain was subsidized, it was available for $5 a gram, fewer than 10% of the patients made use of that service. The cannabis was of very poor quality, and even if it was the best quality cannabis in the world, by making a single strain available, they were cutting out a whole bunch of people for whom that strain wouldn't work. So to date, there's about 150,000 Canadians who obtain authorization to use medical cannabis, but studies suggest about anywhere between 500,000 and 1 million Canadians claim to be using medical cannabis. We still see that the overwhelming majority of Canadians are not part of the federal medical marijuana program, despite recent significant growth in the program. So Tilray is one of the licensed producers. There's 38 in Canada who are producing cannabis on a large scale. Tilray is really moving forward with commitments to take on clinical trials, to really advance the knowledge and understanding of medical cannabis, not just in Canada, but around the world. And we're doing studies right now, phase 2 clinical trials on pediatric epilepsy, on COPD, on cancer chemotherapy as a treatment for nausea and vomiting, and on PTSD as well. And we're the only GMP certified medical cannabis production facility in North America. So there's probably better people at the conference to talk about the biological effects of cannabinoids, but I did want to mention a few things. There are over 100 unique cannabinoids in the cannabis plant. The one that's best known is THC, of course, which is responsible for the psychoactive effects. And CBD is growing in prominence as well. If you've heard about the use of cannabis in the treatment of pediatric epilepsy, those are typically high CBD strains or extracts. Cannabinoids are thought to have their effect on the endocannabinoid system, and THC binds to CB1, which mediates its psychoactive effects. And cannabinoid receptors are responsible for a number of major areas in terms of the effects on humans, including memory, sleep, anxiety, mood, stress response, and inflammation. In terms of the pharmacodynamics of THC and why we think that cannabis might be useful in treatment of PTSD, well, THC is a powerful analgesic, muscle relaxant. It has antiemetic properties, so it deals with nausea and vomiting. It's appetite stimulating. It has, of course, well-known psychoactive effects, and it's an immunomodulant. In terms of CBD, it's also an analgesic, but not on par with THC. It has muscle relaxant effects. It's anxiolytic, which means that it reduces anxiety, at least in some cases, some of the time. That's a bit of a controversial area right now, but certainly that's one of the reasons we're looking at it in the treatment of PTSD. It's neuroprotective, antioxidant, and it has some antipsychotic activities as well, at least in preclinical research. The rationale for cannabis in the treatment of PTSD is supported by some clinical and preclinical research. So Greer et al. Found that cannabis was associated with a 75% reduction in 3 areas of PTSD symptoms, including re-experiencing, avoidance, and arousal, compared to cannabis-abstinent participants. There's some really exciting research, some of it which took place in Canada, that's also found that nabilone, which is a synthetic cannabinoid, has been shown to be effective in reducing PTSD symptoms, including nightmares and insomnia. And if you can fix that alone in PTSD patients, you can have tremendous treatment outcomes for people who are affected by severe nightmares and reoccurring nightmares. Medical cannabis has also been associated with reductions in the use of opioids, and that's research myself and Dr. Walsh, my colleague Amanda Ryman, who presented yesterday, have found as well. And I'm going to share with you guys some new research on medical cannabis and cannabis substitution now. So this year in January, I conducted a large-scale survey of Canadian patients. Tilray provides medical cannabis to patients throughout Canada, and we sent out a survey to our patients. It was a 239-question survey, available in French and English, and we were hoping to get somewhere around 2,000 responses to the survey. We were going to leave it open for a week, but the responses were so overwhelming that we had to shut it down after 48 hours. We got 3,400 responses. That's one thing that I think everyone on this stage can attest to. Medical cannabis patients want to share their stories. They feel alienated from the traditional healthcare system. They want to share what's happening with them. So they make great survey subjects. Out of the responses we got, 2,032 provided a Tilray patient number, so we knew they were valid patients. The average age was 40 years old. We saw an overrepresentation of males, which is what you see in the medical cannabis program in Canada and also in U.S. medical cannabis programs. There's no real reason for that beyond the fact that men are more criminogenic. We're more likely to do things that are criminal or a little bit outside the law, and therefore we see more men using cannabis in general and using medical cannabis as well. I always ask patients, what's your primary condition? And they can click one box. I've been doing surveys like this for about 12 years. And I ask them also, what's your primary symptoms? Where you can click multiple boxes. Because, of course, if you're an MS patient, you might have symptoms of chronic pain, insomnia, and or digestive disorders. So in this case, when I ask patients about their primary conditions, we really see pain and mental health as the primary reason why patients are using medical cannabis. So despite the fact that there's been controversies around cannabis, its association with psychoses or schizophrenia, you see that certainly in this survey, and this is the first survey I'm aware of that found this, the main primary conditions why patients are using medical cannabis in this case are mental health. So a combination of insomnia, mental health, and PTSD. We also see pain, arthritis, chronic pain, and headaches coming in a close second. Now, when we ask primary symptoms, you see that chronic pain is reported as the primary symptom at 57%, but that's closely followed by anxiety, insomnia, and stress. So once again, you get a sense of why medical cannabis might be useful to treat PTSD. I'm really interested in substitution effect because of its public health and policy implications. So I've refined the way that I examine substitution effect in surveys over the years. So I now ask patients, have you ever used or are you currently using a substance? Whether it be prescription drugs, alcohol, tobacco, or illicit substances. And if they say, yes, I have ever used or I'm currently using, then I ask them, well, have you ever substituted for? It gives us a more refined way to look at substitution. So in terms of prescription drugs, 69% of the participants say they substituted for prescription drugs. For alcohol, 44%. For tobacco, 31%. And that's only the second time I've asked about tobacco, and it's really remarkable to flesh this out a bit because of its public health implications. And then illicit substances, 26% of ever use, of ever or current users have substituted. I get more granular as well. I ask patients to cite the 3 prescription drugs for which they're substituting for. And in this case, we see that 35% of the substitution is for prescription opioids. No surprise, patients are using it for chronic pain. That makes good sense. And also knowing that patients are using cannabis for mental health conditions, it's no surprise that 21% of patients are actually substituting for antidepressants, SSRIs, SNRIs, etc. Now, when I used to do presentations like this, doctors would say, yeah, but how much are they substituting? Is it just once in a while? I mean, are they using a joint once a year instead of popping an opioid? And so I wanted to answer that question. So I asked patients to cite whether they were substituting 100% of their opioids with cannabis, 75%, 50%, or 25%. And it turns out that 458 patients report substituting a total of 608 opioids. And of the 608 opioid mentions, patients were able to stop use of just under 60%, stopped using them completely. So 100% gave up those opioids, and then another 18% gave them up by 75%. So this is incredibly significant, knowing that opioids are right now the largest cause of accidental death in North America. And that we're really going through an opioid overdose crisis, which is also, which is even more serious when it comes to patients with PTSD and vets. I also asked the same question about alcohol, and it turns out that 31% of participants say they substituted cannabis 100% for their alcohol use. They give up alcohol completely, 36% reduced their use by 75%. And tobacco, which is really underreported when it comes to cannabis and use in terms of complement or substitution, I found this remarkable. Of the 406 respondents who substituted cannabis for tobacco, 50% say they stopped it completely. Now, other than psilocybin, interestingly enough, I don't know of another tobacco cessation agent that is that successful, where you get a 50% success rate. So it's quite remarkable to me to see that kind of change, that kind of impact. And I think that this bears, obviously, further investigation. We're not the only ones who have found this. Yesterday, Amanda Ryman did a great presentation on new data that she's got on cannabis substitution effect from a large-scale survey. We also saw, interestingly enough, that, I don't know if you guys know this, but in Canada, Veterans Affairs Canada pays 100% of the cost of medical cannabis for vets, police, military, and correctional agency vets in Canada. So they track the use of medical cannabis and the use of other prescription drugs. And at the same time, they've seen this massive increase in the use of medical cannabis by the veteran community. They've also seen a 30% decrease in the use of benzodiazepines and a 16% decrease in the use of opioids. So really significant. We also saw that from Backhuber and all in 2014, in an amazing article in JAMA, that medical cannabis states had a 25% lower mean rate of overdose mortality, opioid-related overdose mortality, which is really remarkable. And the amazing thing about that finding is that the longer the medical marijuana program was in the state, the greater the impact of that program. In other words, the more opioid reduction overdose deaths we saw. And finally, Bradford and Bradford last year came out with a great paper that showed that for seniors in Medicare programs, they saw significant reductions in prescription drug use rates or prescriptions in states with medical marijuana programs. And when it came to anxiety, you actually saw that the annual doses prescribed per physician fell 560 doses, which is quite remarkable on a per physician basis. And finally, I'm going to ask Germaine to play a short clip of a movie of a young lady who's using medical cannabis right now to treat her mental health condition and PTSD. Thank you very much, Germaine.
I started to feel not 100%, probably when I was in about grade 7 or 8, when I fell into some major depression, anxiety, problems sleeping. Started with guidance counselors at the school, then moved on to counselors just at some clinics, moving on to psychologists and psychiatrists, and I was put on lots of different medications right from 14 years old. First was trazodone, which was to help me sleep, and then it was the trial and error with lots of antidepressants. Wellbutrin, Prozac, Effexor. Some of them made things feel worse, and everything it never felt level. Diagnosed with PTSD only in 2014, but I was living with it since I was about 15 years old. Medical cannabis was something that I kind of was listening about in the media. At first it was like, which strains do I choose? What do I choose? How does this work? And I was able to kind of find a few strains that worked good for my ailments. Sometimes it's almost instant relief after vaporizing the cannabis. The feeling of being level in your head and in your body, it comes pretty quickly. Cannabis has replaced almost completely my antidepressants I was on, my sleeping pills I no longer take at all, and as well as my ADHD medication. It was something that was able to lower my anxiety enough to dive deeper into therapy, which opened up the door to help me deal with the deeper issues of my PTSD. My life is actually a life now. I have friends, I go out, I have family that I enjoy doing things with. It's just opened up my life to so much more possibilities. The first thing that I read about Tilray was an article about PTSD. So that is what kind of drew me towards them, because I wasn't reading much about PTSD otherwise. The customer service has been beyond for me. Anytime I had a question about anything I was ordering, every question was always answered either instantly or I was gotten back to within a reasonable time frame. Gotta be one of the most significant things that cannabis has helped me with is this idea of having hope, being hopeful about a future, hopeful about life, hopeful about my health. that has been such a significant change because of cannabis. It's just so hard to emphasize to people how much my life has changed because of this. The way that it's turned my life around completely from where I was, I just would hope that it would help someone else in the same way.
Thank you, Jermaine. The story of just one young lady, but I'd like to say that, when you hear something from one person, it rises to the scope of anecdote. When you hear it from dozens and dozens or hundreds of individuals, including a gentleman who came up to me today and said that he's already done our study and found it to be successful on himself, it rises to the level, as a social researcher, I'd suggest, of community-defined evidence. And all we're doing right now, the people on this stage, are trying to add some clinical data to what we know in terms of community-defined evidence. Seems to be helping patients so much. So thank you very much. We'll take some questions at the end of the presentation. Professor Zach Walsh.
Thank you very much. I'm talking this one. Thanks so much. It's really such a thrill to be here, and it's just great to be able to present with Dr. Sisley and with Philippe. Philippe has been just a tremendous mentor and partner to me in the last, I guess, 5 to 10 years I've been doing cannabis research, so it's always a thrill to speak with him. And in terms of disclosure, obviously getting research support from Tilray to do the study. They don't cover my salary at all, but they support the research and support the students that are working on the project as well. We also get some matching funds from the Canadian government through a program called MyTax. It's very helpful to us. So I've got to say, as an academic researcher, it was never in my horizon to be working with industry. It was never something that I had intended to do, but it's been an absolute pleasure, and Tilray has been so supportive, and really couldn't do it without them. We're so fortunate in Canada to have high-quality producers of good cannabis for research purposes. It really opens a whole new horizon, and until we had our licensed producer program, and I guess 2014 was it that came on board? There was no access to good quality cannabis. So it's been great working with Tilray. So again, we've gone through the UBC ethics, and I'm not going to be describing any study results, so no bias there. So I want to talk about cannabis for PTSD and talk about our study a little bit. I also want to share the results of a recent review more broadly of cannabis and mental health. It's one of my main research interests, and we're really excited just earlier this year when our paper came out in Clinical Psychology Review. That's an APA journal, American Psychological Association journal. It's one of their most high-impact journals. So we're really excited to see this come out, and I think it provides a nice balanced view of cannabis and mental health. And one of the things we talk about are substitution effects a little bit, cannabis in the context of problematic use of other substances. I think Philippe's done a wonderful job of covering that in some detail, so I'm not going to get into that. But what I would like to point out, first of all, if anybody wants to get a copy of this article, just email me. My email's at the end of the presentation. But we do talk quite a bit about substance use, and one of the recommendations that I was really proud to be able to make in this review, coming out from a very mainstream journal, is that cannabis use, there's no evidence that it interferes with the treatment for problematic use of other substances. And so there's so many barriers for people getting the help they need when it comes to addictive behaviors. Using cannabis shouldn't be one of those barriers. So if you're trying to get treatment for other substance use, there's a lot of treatment facilities that will ask you to be abstinent from cannabis as well. And what we say in this article is that is not, should not be a prerequisite, that it's in fact an unreasonable barrier to accessing needed services. So if there's clinicians out there who are of the same mind and are looking for some backup on that, it's in print. So just to get into the review article, the literature on medical cannabis, because of some of the barriers that I was talking about to doing clinical trials, and I'm sure we'll hear some more about that later, the literature on cannabis for therapeutic purposes, I sort of prefer that term to medical cannabis. It makes it sound like it's a different product. But so cannabis for therapeutic purposes. The literature is largely cross-sectional. It's a lot of surveys of medical cannabis users. It's not based on clinical trials. But nonetheless, it is pretty broad. We looked at all of the research that talked about mental health. We went through the whole DSM, looking at all the different mental health conditions and medical cannabis use. And it's about 24,000 participants across all those studies who have reported on their use of medical cannabis for mental health conditions. And a lot of them are from California, some are from Canada, there's a few from Australia as well, but it's largely cross-sectional, so that's a bit of a limitation. Another limitation of much of that research is by drawing from medical cannabis patients, you're drawing from people who have already found medical cannabis to be efficacious. Given the barriers to accessing medical cannabis in so many jurisdictions, if people are going to try it and it's not going to work for them, they're probably not going to stick with it. So I think it's fair to suggest that this is somewhat of a biased sample when we look at the medical cannabis users because they've already fought to use medical cannabis. So that's worth noting. So we wanted to supplement it with a research on non-medical cannabis use. But that has got a lot of problems as well, including a myopic focus on problematic use, and also a substantial confound that comes from a prohibition bias. So when we're looking at non-medical cannabis use, a lot of it comes from treatment facilities, a lot of it comes from perhaps correctional populations, and in general, if people are willing to break the law, to use cannabis, the unfair law against cannabis, but still, if you're willing to break the law, that has certain personality characteristics in small levels. You know, I'm speaking as a lawbreaker myself, but that has certain personality characteristics of perhaps impulsivity or just general rule-breaking behavior that when you look at large samples, that could also be associated with things like anxiety and depression. We know that those things are related. So that research is confounded, and not to get off topic, but that's particularly true when you look at the adolescent literature on mental health. When we're looking at frequent adolescent cannabis users, we're looking at adolescents who are breaking the law several times a week, and that is a specific population with, positive and negative traits, but it's going to increase the observed association with things like anxiety. So, having said that, because the non-medical use of cannabis has been so widely studied, there's no way you could do a systematic review of all of it in mental health, so we did a review of reviews. So this is everything that's been looked at for medical cannabis and mental health, and a review of reviews for non-medical cannabis. And what did we find? Starting with anxiety, there's 8 studies of medical cannabis use in anxiety. In all of them, people reported relief of anxiety. In one of these studies, the anxiety returned upon cessation of cannabis use. So whether that has to do with cannabis withdrawal or whether it's that cannabis was dampening the symptoms and they come back up when cannabis was stopped, unclear. 2 reviews of non-medical cannabis use in anxiety, and they find a small positive association but nothing causal. So as I was saying, there's this prohibition bias where we're looking at a population that are involved in rule-breaking behavior, and we're going to see some increased anxiety there, but nothing causal. And of course, it could be that people who are higher in anxiety, even outside of a medical setting, are using cannabis to treat their anxiety, even though they may not identify as medical users. So no causation in that anxiety study, but nonetheless a small positive association in those reviews. See something very similar with depression. There was 9 cross-sectional studies. 7 of them noted improvement in mood as one of either the main effect or beneficial side effect of using cannabis for therapeutic purposes. And in one case, the more depressed people were, the more problems they had with their cannabis use. But in general, across those 9 cross-sectional studies, the vast majority showed improvement in mood as one of the main motivations. In our reviews of the non-medical literature, very much the same thing. A small positive correlation, but nothing that can be associated with causal effects. It could be that depressed folks are more likely to try to treat their depression with cannabis. It could also be that there's something to do with the character of people who use cannabis in a prohibition environment. A lot of attention to psychosis and schizophrenia, as I'm sure you're aware. I'm not going to do that topic justice, but what we will say is that this is an area where we do see some increased risk. Many of you probably know that the use of cannabis has increased exponentially since the 1960s across North America, Western Europe, etc., with no accompanying increase in the base rates of schizophrenia. So that argues strongly against any kind of causal association. There is some evidence that using cannabis can lead to an earlier break, and of course that's something that we want to avoid. So individuals at risk for developing psychosis may develop it earlier if using cannabis. So some risk there. However, in our review of the medical literature, we found no reports of medical cannabis users developing psychosis. So that seems to me to be the type of thing that if it were to emerge, even in a case report, that would be documented somewhere in the literature. So with all the millions of people using medical cannabis, millions of adults across the US and Canada, we haven't seen any reports of psychotic breaks. Neurocognition, something that we're really important. If we're using a medicine, we want to know what are the neurocognitive impacts. Of course, that's something that's been widely disseminated as a problem with cannabis. There have been few studies of it in the context of medical use. There's one that I have to add because it came out after this review, a small study of 11 individuals who are using cannabis in pain conditions, and they showed a small increase in neurocognitive function that was attributed to reduction in opioid use perhaps, and perhaps also a reduction in symptoms. In the BEST study of medical use of cannabis that looked at neurocognitive functioning, there were no differences at 1-year follow-up. So these are people who are using cannabis frequently, and this is the COMPASS study out of Canada. And it's been well reviewed in the non-medical literature. And just to summarize briefly, because this could be several presentations, what we find is some short-term deficits in memory and perhaps some executive functioning deficits, but that those resolve after a month or two of abstinence, so no permanent deficits. Also interested in harms, of course, harm to self, harm to others, and we find in reviews nothing on this will come as a shock to you, but using cannabis medically does not make you violent. And the literature bears that out. Yeah, no substantial relationship between between non-medical cannabis use and violence, either towards others or towards the self. So these reviews are all inconclusive. So the risks are very manageable. It appears that there is some potential for treating anxiety and depression. And when we look at the PTSD literature, I think Philippe did a great job of summarizing the main studies. There's 4 studies of medical use, making this the area where we have the richest literature on medical cannabis and mental health. And what we find is that a lot of folks with PTSD report using cannabis to relieve their symptoms, particularly associated with sleep and nightmares, and in general, self-report of good outcomes. So given that, it's the piece that's missing are the clinical trials, and that's where I want to move on to now and talk a little bit about our trial, and Dr. Sisley will finish up talking about the parallel trial that's going on in the States. So we know it's safe. We know that people say it works. It's time to look at it using clinical trials. So here's our protocol design. It's a randomized clinical trial, placebo-controlled, with 2 active treatments and a crossover stage. So folks who are in the placebo condition will eventually get an active treatment later. And those who start an active treatment will get a different strain in phase 2. We're looking at 42 participants in total. And the main thing we're looking at is CAPS scores. For those of you who have been attending talks throughout, you know the CAPS is sort of the gold standard for assessing PTSD. So our question is, we're comparing, and one thing that we're really excited about in this study is we're able to compare a THC, I won't call it 10% a high THC, but a THC strain to a balanced THC CBD strain. So this is I think the first study to do that. And you know, there's so much interest in the cannabis community about different strains, but we haven't tested those out yet. And this is, of course, a very preliminary step in examining strains. There's so much diversity there, but looking just THC at CBD seems like a good place to start. So people have to be abstinent for 2 weeks. We have a pretty good access to medical cannabis, not as good as it ought to be, but particularly in the region where we are, a lot of folks with PTSD who are interested in using cannabis are doing so. So our requirement of 2 weeks of abstinence before starting the study, I think has been a bit of a barrier to enrollment, because folks who are using it effectively don't want to quit for 2 weeks. I can totally understand that. We wouldn't ask them to. Nonetheless, that's required. They have to stop for 2 weeks, and they start with one strain, stop for 2 weeks again, start with the next strain, and then 2 weeks at the end as well. So we ask for those abstinence periods and certainly appreciate the willingness of our participants to do that. One of the bonuses is they get to take home a vaporizer. That's one of the differences between our study and the U.S. study, I believe, is that we're looking at vaporized cannabis. Storrs and Bickel were nice enough to provide us with a bunch of vaporizers, and they keep them at the end of the study. So it's vaporized cannabis ad lib. People use as needed in their comfort of their home. So our 42, you can see the 3 conditions and the crossover. T100 and T200 being the names of our 2 strains. Not as catchy as a lot of the strains that you guys are familiar with, but what you going to do? It's science. We also look at a bunch of other things aside from PTSD, some of which we're interested as potential moderators of the effect, some of which are secondary outcomes. So we monitor for suicidality very closely. We're also looking at concurrent alcohol use. We want to see quality of life. So it's not just about symptom reduction, it's also about a broader assessment of quality of life, which I think is so important in studies of cannabis, because yes, we'll see symptom reduction, and wherever you target your symptom assessment, you may see some reductions, but overall quality of life, very important, and I think one of the great benefits of cannabis as a medicine. We also look at some other stuff. Distress tolerance, I think, is an important potential moderator. Cannabis, I think, not only reduces symptoms, but it can also reduce people's relation or change people's relationship to those symptoms and how tolerable they find them. We're also looking at intimate partner violence, which relationship conflict can be part of PTSD, a real troubling part, because it can drive away the supports that you need the most, due in part to irritability and isolating. So we're looking at relationship factors as well, looking at concurrent anxiety and depression. Sleep is a big target. That's where some of the action is likely going to be found for cannabis as a treatment for PTSD, improving sleep, reducing nightmares. People are not the best at reflecting back on their sleep. If you ask them, how was your sleep last week? Or even, how was your sleep last night? Especially if people are suffering with depression, they tend to overestimate how poor their sleep was. It's just a hard thing to self-report. So we're using actigraphy to monitor people's sleep. So we get an objective measure of sleep as a potential mechanism. Just one more time to summarize the visits. So you come in, you get screened in or out, unfortunately. We do an introductory session after the 2-week cessation. They come in for 3 weeks of treatment. They come in once a week. We call them every day in the first week to see how people are doing and monitor for suicidal ideation, just to be extra cautious, since this is one of the first studies of cannabis, the first one of cannabis for a mental health condition in Canada, so we want to satisfy Health Canada that we're being very cautious. Come in once a week. They get 7 2-gram vials of cannabis, so 2 grams a day is our limit. We ask them to just use what's in what they use, and then return the rest of us to us at the end of the week, so we can get a very careful assessment of how much they're using. And then each week they get a new set of 7 more vials with 2 grams apiece, and we do that for 3 weeks, 2 weeks off, and then stage 2. So that is our study. I'm so glad to be able to share it with you, and please don't hesitate to contact me if I can be at all helpful. And I think you can still see my contact information there at the at the Therapeutic, Recreational, and Problematic Substance Use Lab at UBC. Thanks so much for your attention.
Thank you, Jermaine. Thank you all so much. I wanted to start off by just expressing our appreciation to all of you who've been following our saga trying to get this study underway. It's been, I think, almost 7 years now that we've been fighting to implement this clinical trial, and happy to say that we're finally fully underway. We have 9 veterans enrolled in this study, which is a wonderful achievement. So I wanted to just take a step back and remind everybody how we ended up pursuing this study. And it really came back to the epidemic of veteran suicide. This is why I'm wearing this dog tag with the number 22 on it. The veterans groups have been trying to build public awareness about this problem that we have, that it's really a public health crisis, that we're losing that many veterans to suicide every day. What's interesting about this number, many of you have heard the number 22 a day. The VA just recently came out with a new statistic that it's down to 20 a day. So the government is now patting themselves on the back, saying, congratulations, look at how hard we've worked. But in fact, what we're seeing is that the government isn't really doing anything meaningful to uncover new treatments for PTSD. They're not really trying to tackle this as a public health crisis. And that's really a tragedy, because these vets deserve so much better. And so that's what, we don't know if cannabis could help curb this epidemic of veteran suicide, and our study isn't going to answer that question, but certainly we all understand that suicide is probably related to either untreated PTSD or undertreated PTSD. So we're definitely hoping to start to shed some light on this. Many of you may not realize that there's only 2 medicines actually approved by the FDA to treat PTSD. So it's just Zoloft and Paxil. That's it. So all these other medications we use that we prescribe to patients are being used off-label, never been formally tested for PTSD. We've been really lucky. You can see even years ago, the media started helping us focus on this problem, talking about how the meds that we're using to treat this illness are really often no better than placebo. And that's the sad reality. This is a little design that we showed at Walter Reed. We got invited to present some cannabis lectures at Walter Reed Hospital last year, and it was really fascinating to see the military docs who were so surprised at what we're allowed to use when Zoloft and Paxil fail. Really, all of these medications are allowed to be used off-label. All the antidepressants from any class are fair game. All of the sleep meds, all of the bipolar medications, the anticonvulsants, the lithium and Depakote, all of the antipsychotics. I mean, really, nobody would criticize. These are all within reasonable practice guidelines for treating PTSD. But you can see why these vets and all PTSD patients get so frustrated, feeling like a guinea pig here, because they're just being put through the gauntlet of all these different medication trials. And in fact, they often get very minimal relief because the PTSD is such a complex constellation of symptoms. So Zach did an excellent job of giving you an overview of the study design. So I'm not going to go into that in much further detail, but I did want to show you, I wrote down a couple notes here. When it comes to, so I wanted to just point out a couple of the differences in our study protocol, and I also really want to commend MAPS and Tilray for being willing to embark on this partnership. It was so surprising. When MAPS shared their protocol with Tilray, it's really rare, right? That scientists usually function very secretively with protocols, but MAPS has always been highly transparent with, they like to post their protocols on their website and share them freely with scientists, and I love that collaborative approach, and the fact that Tilray was willing to embrace this and fund it and do such a good job of launching it. We're really grateful to both parties. This is actually not this is an old slide, but I just want to point out that we have 4 arms in the study instead of 3. So we have basically, the percentages aren't totally what we got from NIDA, but basically we have 1 arm that's high THC, 1 arm that's similar to that 1-to-1 ratio of THC to CBD. Then we have 1 arm that's a high CBD with CBD and virtually no other cannabinoids. And then, of course, we have a placebo control. We certainly wish that we could use cannabis from Tilray instead of the NIDA cannabis that we're forced to use. But so we're really eager to see how these results compare. And the one thing that I thought was a really important part of the protocol was this familiarization session, the intro sessions, where we have an opportunity to teach the patient how to dose the medication, and how to, and then we get to observe their response in the lab. And this was also one of the big challenges to getting the study implemented. This was the very thing that caused us so much problems with the University of Arizona and with virtually every other institution that we tried to work with. The fact that we are actually giving patients medicine on site caused us all sorts of, that people didn't like the optics of having veterans smoking weed on their campus. But this is a really important, it's a crucial part of the protocol, right? Because it enables us to see firsthand what side effects they might be experiencing, what pleasant drug effects they might be getting. And it enables us to document that and also give them a comfort level. We have a number of vets in the study now who are who've never used cannabis before, or who may have used it when they were a teenager, but essentially are completely naive to it. And so to be able to retrain them or to train them for the first time in how to use this and kind of alleviate some of their anxiety about this has been really crucial. So rather than, I think we have, so like Zach did an excellent job with this. So I'm going to actually, Jermaine, if you can just jump to the PowerPoint, because I know we're short on time, and I wanted to just show you a couple things. I wanted to kind of leave this on a positive note and give you some things that I think give me some hope for the future about cannabis. So Nora Volkow, she's the longtime director of NIDA, the National Institute on Drug Abuse. And I sat through a lecture recently where she presented this material, and I was really encouraged. Nora has been probably one of the biggest anti-cannabis crusaders in the country, and for her to acknowledge that cannabinoids have a role in pain management, this was to me a very big breakthrough. And she gave me your slide, so I thought I would share that with you, because I think that the fact that the head of NIDA is now acknowledging this has real value is important. And then, of course, I don't know if folks touched on this in previous sessions, but this NAS report is probably one of the biggest game changers. This respected federal agency, the National Academy of Science, releases this report in January. Suddenly we have 400 pages documenting that cannabis is a medicine. I mean, this is for the federal government to, this federal agency to admit that cannabis, they basically did an analysis of over 10,000 studies and ranked them all in terms of scientific credibility. And they admitted that the science on cannabis for chronic pain, for multiple sclerosis, and for nausea and vomiting associated with chemotherapy, and those three areas had strong scientific evidence. And then they admitted that there was, mild to moderate evidence for a variety of other areas. Certainly not, not a sweeping endorsement of cannabis for all the conditions that it's traditionally associated with in these different legal states, but still an incredible, evolution compared to their previous report. And this is a really useful tool. So I wanted to encourage you. You can easily find this online, or you can, I'll give you my card after, and I'm happy to send you this report. We've used this very effectively with elected officials because they're all so afraid of the federal-state conflict, and now to see a federal agency come out, with such a vigorous endorsement of cannabis as a medicine was a real breakthrough. So, and then this is the final thing I just want to mention. You're going to continue to see the American Legion becoming a major advocate in this area. This is tremendous. For those of you who don't know, the American Legion is probably the most powerful veterans organization in the country. Very conservative, 2.5 million veteran members. They meet with Trump and his staff regularly. And they are talking about the fact that this is at the top of their legislative agenda. This is all new, right? The American Legion had never taken a position on cannabis ever, because they were so afraid of how politically radioactive it was. And suddenly, we spent years trying to persuade them to get involved in this because they have so many veteran members who do care about this, and finally got them to pass a resolution last year, and we got to speak on the main stage of their national convention in front of 10,000 veterans, and Trump and Hillary were on stage with us. This was still during the campaign, and talking about this study that we just outlined here. We actually got to present the study design and talk about the science of cannabis as a medicine. So they passed the resolution. Now it's officially part of their public policy effort. So keep your eyes out for this, because if you work with vets who have, you're going to see more resolutions about cannabis coming out in the next year. And I think this has they have the most hope of probably influencing this. They could be the tip of the spear for us and really help us begin to see some major breakthroughs in federal reform. So I think I'm going to leave it at that, and then we'll do some Q&A. Thank you all so much. Thanks, Bud. Thanks, Zach. You too, huh? Thanks, Bud. Yeah,
Hello. I have a question about whether you know any research or anybody studying how psychotherapists are basically talking about medical cannabis or using it, or their attitudes towards it and using it as part of therapy, or just dealing with the issue of clients who are using it on their own.
I'm a therapist as well, a clinical psychologist, and that was part of the inspiration for doing that review. Is I was getting colleagues saying, "What do I do with medical cannabis patients?" There was a time when I suppose people could just dismiss it, but now that we have medical cannabis, they're saying, "This is a legitimate thing. How do I deal with this in my mental health practice?" So we're trying to address that, absolutely, and there needs to be more guidance, I think, for mental health practitioners to understand. I think we're at the stage where we have to get them to understand that it's okay and it can be helpful, and it's not just some kind of explanation for whatever.
To abuse drugs and
I mean, drug-seeking behavior, if that's a thing. But I think it's important that now we take that next step and see how can we develop therapies that are going to work with the medicines that our patients are using, and how do we maximize the clinical effectiveness of cannabis through behavioral interventions. So I'm looking at that synergy. That's very interesting.
Very much.
I have a question about this study with smoking cessation. Did you, because it's amazing for the 50%, but did you happen to assess when the person quit? Because it would be even more impressive if they had been abstinent for a year or 6 months.
No, not at all. I think that'd be a great next step. This is just a cross-sectional survey, and so it's retrospective. We ask patients, and the smoking data in particular is what got me to change this question, because 2 years ago I have a similar survey that was published recently in International Journal of Drug Policy. I found 12% of respondents said they substituted for tobacco, but it occurred to me that that was just out of 100% that were asked, have you ever substituted for tobacco? I realized at least 50% of those would have never used tobacco. In other words, they weren't regular smokers, so why would they be substituting for it? And that realization made me change the way that I ask about substitution. That's why I ask, have you ever used or are you currently regularly using tobacco? And then that subgroup I ask, are you substituting for? And that's how we got to those numbers. But I was both surprised by the 36% who said that they substituted for tobacco, but even more surprised to see 50% saying they quit tobacco altogether. I should say that, I'm a medical cannabis patient who uses it who started using it in 1995 for Hep C, but initially I started using medical cannabis because at the time my doctor said there's no cure for Hep C, you've got to stop using tobacco and alcohol, and I actually used cannabis to deal with the cravings of tobacco. That was my primary reason for use and for medical cannabis prior to realizing it was actually helping my Hep C. So it did ring true to me personally, but to see that it had happened to so many other people was quite remarkable.
Wow, thank you.
Good morning. Not really sure how I want to formulate the question because I don't know the science well enough, but my understanding of the way cannabis works for PTSD, particularly in the veterans who are smoking huge quantities of it, is that it suppresses memories and it helps sleep and it reduces the startle and the self-guarding and all of that. Whereas my understanding of the standard treatment of PTSD is you actually have to confront the memories. You actually have to bring them back into consciousness. And this is precisely what the MDMA studies do, and they bring the memories into the MDMA space, and that permits them to be reintegrated and relearned. So I guess my question is, are you seeing cannabis use in PTSD as strictly symptom control, or is there any thought in any of your theoretical frameworks that might suggest that there's any other way to use cannabis that might be curative in the way that MDMA can be curative for some people? Thank you.
Maybe I'll just answer briefly and then pass to Sue because I'd love to hear what she has to say about that. I've worked in VAs and as a psychologist and done some of that exposure therapy, and I think whether with or without MDMA, reprocessing the trauma is very important. But when individuals with PTSD start spiraling into that sleeplessness, the anxiety, the hyper arousal that scares off their supports and that stops them from getting a restful sleep. What I think that cannabis can do, as you note, by suppressing the symptoms, is allow people to start to get a life back, and then perhaps some of the positive things that come from living a more structured and acceptable lifestyle can be curative as well. So there is the reprocessing that's important, but a lot of folks, I believe, cope with or somehow overcome their PTSD symptoms without reprocessing, just by developing other supports and developing a life worth living. And I think that cannabis can work there, and perhaps when someone gets to that point, then they're going to feel that strength to be able to do that difficult reprocessing. Because the fact is that as effective as reprocessing is, a lot of folks with PTSD are reluctant to walk through that hell, particularly if they're not sleeping and they're isolated. So I think the symptom reduction is not just symptom reduction, it's a step towards building a more stable and acceptable life.
Perfect answer. No, he nailed it. And I just saw we're on yellow, so I didn't want to do it. But that was, I think we all believe that this is probably primarily symptom control, but Zach really eloquently explained how
Thank you.
it's beyond that.
Thank you very much for what you guys are all doing. Outside of your study, are you finding that PTSD patients are finding more success with particular varieties? For example, I've heard that Kush strains are popular with PTSD. Is that right?
Yes. I honestly, I don't even know how to begin that, because in Arizona, we don't even have lab testing required. So we have a medical cannabis law, but we don't really know what people are getting, so I don't have a good hand. You guys?
In Canada, we're certainly seeing that the higher THC strains seem to be what patients are looking for. It's going to be interesting to see how that plays out with our joint studies, because we're using what we're calling high THC, and it is, for the sake of clinical trials, is only 10% THC. To get a 10% THC strains, we have to harvest it at 5 weeks. And anyone knows who, anything about cannabis, we're harvesting early to keep it that low in THC. Tilray doesn't actually sell a strain that's low in THC otherwise. So it's interesting to note that, I think the real question, the equipoise in our study, as much as seeing whether or not there's efficacy here, is whether the addition of CBD is going to be effective. And certainly in the US study, which has an additional arm that's pure CBD, whether just CBD alone can lead to symptom relief. And that's really where the questions are. But typically, vets in Canada tend to use high THC cannabis. That seems to be the predominant use. I also want to use this moment just to thank Nick Giacomis, who helped me with the analysis of the substitution effect stuff. He's my colleague from Leafly, and so he's here with us today too. Thanks, Nick. Much appreciated. And in case this is my last chance at the mic, I really want to thank Rick Doblin, all the amazing volunteers at MAPS. This is a remarkable conference. I know every one of you know that. You've been here for a few days, at least a few hours. I know Sue just joined us. There's nothing else like it really anywhere in the world, in the academic world, and I wish it could be yearly, but thank you for doing it at least every couple of years, Rick, and the rest of the team.
And in 2 years, we'll hopefully have data that will help, uncover that. But I wanted to point out that we're still two years away from having published data, so.
Nothing teaches you patience like clinical.
Hi, could any of you speak to the suggestion that in persons who develop PTSD, they may have a dysfunctional endocannabinoid system?
You guys, go ahead.
I think that, I don't want to take up too much time on this, but I'd really refer people to Ethan Russo's work on endocannabinoid deficiency syndrome, which is a theoretical construct that he's developed to look at certain conditions that seem to benefit from endocannabinoid or exocannabinoid therapy that don't benefit from other therapies. And he's listed amongst those Crohn's disease and other GI conditions, migraine headaches, and as well as potentially, kind of stress or trauma conditions. Obviously, when any of our major symptoms in our body get over or underregulated, you see symptoms come out of that, whether it be, overactive immune systems leading to arthritis or underactive immune systems leading to HIV/AIDS, et cetera, or being reflective of HIV/AIDS. So I think it only stands to reason that if we had a deficiency in endocannabinoid system in terms of either producing endocannabinoids or being able to absorb those endocannabinoids effectively and process those effectively, that you would see resulting symptoms, and that phytocannabinoids or plant-based cannabinoids, exocannabinoids, might be useful in treating some of those conditions. Check out Ethan Russo's work on it. It's really worthwhile checking out. We're out of time. Thank you all so much. And